everyone, again, thank you for your attention and for your attention during our technical difficulties. We appreciate that. So again, I am Tanshia West, and I am opening up this session. This is our session on optimizing the global impact of health interventions through novel research partnerships and knowledge exchange. So this is our satellite session. I, again, am hailing from the Department of Health and Human Services, Health Resources Services Administration, Office of Global Health. And I will be sharing with you a little bit about our work as well as our partnership with NIH. So, okay. Now, it's my pleasure also to bring on this illustrious panel of speakers, and we have concurred slightly on a bold proposal. Okay, what is that proposal? Global health reciprocal innovation, bidirectional learning, and knowledge exchange can make a big difference. I hope you agree. All right, and health programming, care, and service delivery. So, since I made this humble assertion, how do we do this? Since I might have pushed a few buttons with that bold assertion, I believe it's appropriate that I read this next quote. You can't connect the dots. You can't connect the dots looking forward. You can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. So what do we mean about this? How can we explore GHRI bidirectional learning? How can we ensure it's mutually beneficial, it's equitable, and multi-directional? And how can we exchange innovations around the world and harness this through low and middle income countries? So this session will discuss this and provide some strategies and some case examples on how we do just that. So before we do this, it is my pleasure to introduce our next keynote speaker here, Ms. Kay Hayes. She's our Deputy Assistant Secretary for Infectious Disease and the Director of the Office of Infectious Disease and HIV/AIDS Policy for the U.S. Department of Health and Human Services. She's going to contextualize this session for you, and we'll discuss at a higher level how the U.S. government and our federal agencies are working together on bidirectional learning. So thank you, and welcome, Kay.
Well, thank you, Tanshia, and I will just start by saying thank you for everyone that is here in this space right now. I'm honored to be here, grateful to be here, and to participate in this session. I'm with the HHS Department of, Office of the Secretary, Office of the Assistant Secretary for Health, but my office specifically is the Office of Infectious Disease and HIV/AIDS Policy. We call it OIDP. You know, the government is full of acronyms, and we would not be falling short if we didn't have our own, so it's OIDP. But more importantly, our office really provides that leadership and management, looking with our federal partners, agencies across HHS. I want to say that in this opportunity to move forward, that I want to give you a little bit of background and sort of the contextual framework that Tanshia talked about. 2 years ago, in Montreal at AIDS 2022, we really had an opportunity then to be joined with Ambassador Nkengasong there and our other federal partners to really talk about a global domestic bidirectional effort. And that's important because there is that commitment as we move forward. Really, to enhance our efforts, the government is committed to ending the epidemic. As we do this work in ending the epidemic, we want to do that for everyone, everywhere. Everyone, everywhere. So along with my office, the Office of Global Affairs, HRSA, the Department of State's Bureau of Global Health Security and Diplomacy, which implements PEPFAR, and the White House, Office of National AIDS Policy, all coming together to do this bidirectional work. You know, we're committed to doing that work because it is an opportunity to have lessons learned. We learn from each other. We work together and we learn together, and we work together in that capacity. You know, as we often say, we know that we have the tools to end the HIV epidemic, but it's more than having those tools to end the HIV epidemic. It is really about having those programs, but implementing those programs and innovations in spaces. We've heard a lot about innovation at this conference, so it's really a tool in doing that. Now, this is a broad perspective and a lot of partners. I'm talking about there are 13 agencies and offices that are committed to doing this work. So as I said from the very beginning, we do not do this work alone. We're talking about federal staff and colleagues from across, learning opportunities, including webinars on health equity. Webinars, and really integrating mental health messages as well. We have to know all of our resources and use all of our resources across the department. I'm talking about prevention, care, and treatment. And then last year alone, we had a full-day virtual forum of bidirectional learning. So that is the commitment from the federal government, to come together to have that full day of virtual learning, if you will, and technical breakouts where you can get together and do a deeper dive. You know, very often you have a larger symposia, so you get to the top level. You want to get down, roll up your sleeves and get into that, and that's where that happened in that technical sort of smaller group settings. I also want to say that the technical planning group was really an opportunity to show that commitment. Leadership, like from HRSA, from NIH, our colleagues working hand in hand. And this group continues to meet, so it's not a one-shot deal. It's not a one and done. This is a continual process as we do this work because it amplifies our commitment to this work. And as I said in the beginning, I want to thank HRSA for having this opportunity to do that, because it's in spaces like this that we continue to get our message out. So with that, you're going to hear from the experts. They're coming up right after me. So I just want to say thank you. There's more information. Please go to HRSA GH Forum at hrsa.gov, and then also hiv.gov for more information. But I'm excited to be here, honored to be here, and so let's hear from the experts.
So next we have actually virtually Dr. Longenecker, which is going to share or define with us what global health reciprocal innovation is. And so we've been talking a lot about that, but we want to make sure we define it for you so you know how we are looking at that in the context of this session. One of the definitions you will hear about bidirectional work is how we purposefully commit to it. And so that's in the definition that Ms. Hayes has just shared in her larger initiative. And the federal agencies are looking at the intentionality around that in terms of how do we do that in a purposeful way? How is it mutual? How does it have equity? And so those will be buzzwords that you will hear. And so feel free to question us about that. Like, what do we really mean by that? I think one of the examples I can give of that is that we create programs and we don't think about this at the beginning in the design phase, right? So we want to do that differently. Also, we want to create structures, right, for this. So like, what are our internal capabilities of doing that? How do we retrofit? Look at what we actually have now and actually build that in. So maybe NOFOs in terms of we putting together notices of funding opportunities. That's another government acronym, right? So how do we do that best?
Hello, my name is Chris Longenecker. I'm a cardiologist and director of the Global Cardiovascular Health Program here at the University of Washington. Thank you so much to the organizers for inviting me to provide a brief introduction for this session on global health reciprocal innovation. Here are my disclosures. The concept of global health reciprocal innovation is rooted in the idea that there are shared challenges to health in seemingly very diverse settings around the world, including both high-income countries and low and middle-income countries. Things like limited resources, transportation barriers, and fractured trust in the health system. By recognizing these shared barriers, we might effectively learn from each other about how to creatively overcome them with innovation. Global health reciprocal innovation has been defined by the group at Indiana University as the bidirectional, co-constituted, and iterative exchange of ideas, resources, and innovations to address shared health challenges across diverse global settings. So, delivering a solution through co-development and exchange of information. Importantly, in contrast to the term reverse innovation, which describes innovation flow from LMICs to HICs, this term acknowledges that there is not one right direction in which innovation should flow. And it also emphasizes the importance of co-creation between developers in one context and implementers in another. We have also begun to conceptualize that there may be multiple axes of reciprocal innovation. It's not just global to local or local to global, but also perhaps urban to rural and academia to practice. Innovation may also flow across fields of healthcare or disease models, like from HIV care to cardiovascular care, or from addiction medicine to HIV care. And adding layers of reciprocal innovation may help us even more effectively find solutions to our shared challenges. Focusing on global health reciprocal innovation, one question that always comes up is how might we identify which innovations are suited to reciprocal innovation? In this approach advocated by Bhattacharya and colleagues, one must first assess program success in the original setting, in this case an LMIC. It must be accessible, cost-effective, scalable, and effective. In other words, what is the evidence that it works? It needs to work in order to be effective in another context. And then once you are convinced that it works, then you have to make sure that it fills a gap in target HIC. It needs to be compatible and novel, and there needs to be a certain receptivity to the idea. In other words, you need to make sure that it fits. This is not the first time we've discussed global health reciprocal innovation at IAS. In fact, last year in Montreal, we brought together investigators from the USA and Africa to discuss lessons learned to improve blood pressure management for people living with HIV in our diverse settings. Some of the collaborations from that meeting continue today. One of the innovations highlighted at last year's session is one that our group strongly believes both works in LMICs and fits in the United States. That is differentiated service delivery, or DSD, for HIV care and prevention in Africa. For HIV prevention, or PrEP, shown here for example, there is really so much innovation going on right now around providing these services to the right clients at the right time with the right health workers in the right place in the community so that not all clients have to come to clinic for care. In work funded by the American Heart Association, we are very keen to co-create a solution to improve cardiovascular health in rural America by partnering with innovators of DSD models for HIV care in Africa. But also to layer on top of that some urban to rural reciprocal innovation by learning from the Black barbershop model, as shown here in this picture, where hypertension care is provided by clinical pharmacists in partnership with trusted local barbers. Finally, I'd like to highlight several potential benefits of a GHRI approach. Reciprocal co-production ensures a role for both developers to ensure fidelity to the innovation, in other words, make sure that it works, while implementers ensure compatibility so that it fits. GHRI can absolutely help improve health equity and reduce entrenched disparities, but it must be done so with intention.
All right.
It cannot be an afterthought, or it might actually make disparities worse. And finally, some of you may recognize the African proverb, if you want to go fast, go alone. If you want to go far, go together. And I would add that if you want to go fast and far, use the GHRI approach. Thank you very much for your interest in this topic, and I wish you a wonderful discussion with the invited in-person and Zoom guests.
All right, that was great. All right. So, I think without further ado, we're going to go to our next panel here. And this panel will focus on approaches and practices. So, this is Dr. Turan is going to talk to us about mental health and global health reciprocal innovation, so that's no surprise. And if that, I will turn it over to her to go ahead.
Okay, thank you. Yeah, it's a pleasure to be here today to give you an overview of some of the what's going on in global health reciprocal innovation to address mental health and well-being. I'm from the University of Alabama at Birmingham and doing work globally. I'm hoping I will be able to advance my screen. I am, yay. So global health reciprocal innovation is something that this talk is really based on an article that we published in BMJ Global Health, and was really trying to highlight some of the innovative things that are going on in this space. So what we did is we highlighted some case examples of GHRI for mental health and well-being, but also including HIV stigma reduction, which we considered an essential part of that. So we focused on 12 case examples. 7 of them were focused on addressing common mental disorders. 3 were really specifically focused on HIV-related stigma reduction. 3 focused on substance abuse, and 2 on more general aspects of family and child mental health. The low and middle income partners and settings that were involved in these examples were in Africa, Asia, South America, and the Caribbean. And these examples all focused on the USA as the high income setting. That's not obviously the only place where this work is taking place. But our examples were working with states including Alabama, Massachusetts, New York, North Carolina, and Texas. And so when we looked across these kind of highlighted examples, we found that there were some different designs that were used. Now, and we're working in the field of mental health and well-being, so most of the interventions use psychological techniques that were developed either internationally or in high-income settings to be used by mental health specialists, so psychiatrists, psychologists, and the like, things like cognitive behavioral therapy. And we saw that a lot of the examples used what we called a sequential design. So in the LMIC setting, they developed a really innovative way to work with a non-specialist to actually deliver these approaches. And after showing success with that, then this strategy was adapted for a high-income setting. And then we also saw fewer examples of what we call simultaneous design. And so we do have a few examples where in both a high-income country and a low- and middle-income country, simultaneous parallel intervention, adaptation, implementation, and testing. So here are just a few really quick examples of some of the ones we highlighted. There is an intervention called FRESH, which is an HIV and intersectional stigma reduction intervention for healthcare settings. And this intervention was originally developed in a multi-country African study. And then later, after success in that setting, it was adapted for a setting in the southern US. And later, iteration has been in the Dominican Republic, and just recently there's a new project that's been funded to adapt it for Guatemala. So this has really been a sequential design, but with communication and collaboration with the previous teams at each stage and working together. Another great example is the Zambama study, and this is a simultaneous design of using the common elements treatment approach for people living with HIV and unhealthy alcohol use. And this is simultaneously going on in both the Birmingham and other parts of Alabama and Zambia. And you can see from the slide, there's a lot of bi-directional and simultaneous learning and teams going back and forth and collaborating with each other to see how this can work in both settings and how they can learn from each other. So through review of these examples, and I think this has been highlighted a bit, there are a lot of benefits of GHRI. There's iterative feedback and learning that can happen. For simultaneous designs, you can share procedures, information systems, and staff across multiple settings. You can share complementary expertise. You can do real-time dissemination of strategies and materials, and also, come up with really culturally and contextually adapted interventions. And this can often result in capacity building in under-resourced locations. There are, of course, some challenges, and you can read further in the paper that we discovered. There can be important contextual differences between the LMIC and HIC settings. There are always a lack of sufficient resources to do this sort of big and complicated work. And then some other barriers around travel restrictions or political will to put some of these things forward. So in conclusion, very brief, this is a really exciting emerging body of work that has the potential to benefit diverse populations in both LMIC and HIC countries, and clear benefits of bidirectional iterative processes and using collaboration and communication. We also think this is an opportunity to reflect on colonial legacies in global health and strive for more balance and partnership. And we're calling for more sort of comprehensive funding mechanisms that can support this kind of long-term multinational interaction, and really not only for mental health and well-being, for other health topics. So I'll acknowledge all the people that have been involved in this, and please feel free to reach out to me at the email here with any questions or comments. Thank you.
Thank you so much, Janet. That was very great and very helpful. So I think we're going to go ahead to our next speaker. All right. So our next couple of speakers will actually divide and conquer this title. And so we are going to speak on the Ryan White HIV/AIDS program as well as the PEPFAR program. What we're going to look at lessons learned in the past and then direction moving forward. So my first speaker is Dr. Jenny Ladikwe, and Captain Apple Patel Larson will follow her. But Jenny, please come forward.
Okay, hello everyone. As Tenchia said, I'm going to be talking about some of the work that we've done in the past focused on bidirectional learning. But before we get started, I do want to talk just a little bit about, tell you a little bit about HRSA and the Office of Global Health. HRSA is the Health Resources and Services Administration. We are an agency in the U.S. Department of Health and Human Services, and our focus really is on supporting equitable health care for the nation's highest need communities. We work both domestically as well as internationally, and with a focus on expanding access to health services to the communities that need them most. And this is done by providing health care in underserved and rural communities. This is done by growing the health workforce. And this is done by addressing the maternal mortality crisis, supporting rural health, and meeting behavioral health needs. This slide really just highlights some of the many activities that are conducted within our Office of Global Health that are really all focused on improving the health of people through global action. And just to kind of help set the stage, I want us to think back in time, and I want to focus on 1990. That was when the Ryan White HIV/AIDS program, which we abbreviate RWHAP, that's when the Ryan White program was authorized. Ryan White is the largest U.S. federal program designed specifically for people living with HIV. I also want to touch on 2003, which is when PEPFAR was launched, the U.S. President's Emergency Plan for AIDS Relief, which we all know is the largest national commitment by any single nation for a single disease. And just to highlight some of the key accomplishments of those two programs, with the Ryan White program, we are providing HIV services to over 500,000 people in the United States, with viral load suppression rates at 90%, which is something that we're quite proud of. And we know with PEPFAR, this has been an investment of over $100 billion, with 25 million lives saved. So part of the work that we're focused on in our office is trying to figure out how can we take some of those lessons learned from PEPFAR, some of the innovations in PEPFAR, because we have really, in many cases, pushed the envelope in the field, particularly related to HIV testing, related to viral suppression. How can we take some of those lessons learned and bring them back to the U.S., and vice versa? How can we take some of the innovations from the Ryan White program and have them benefit PEPFAR? So I'm going to talk about 4 different programs that we have implemented, really looking at how we can share best practices and lessons learned to help us move that needle to ending the HIV epidemic as a public health threat. So the first one is MEPI and NEPI. Raise your hand if you've heard of MEPI, NEPI. Okay, I see a few hands. Good, good, good. The Medical and Nursing Education Partnership Initiatives were really created to address the challenge of insufficient healthcare workforce in many of the PEPFAR countries that we've served. Through the MEPI-NEPI program, we created a robust community of practice that includes over 60 medical schools in sub-Saharan Africa, as well as close to 30 medical schools throughout America and Europe. And this has really had an amazing catalytic response to helping create a platform for an exchange of innovative approaches, specifically focused on health worker education and health worker research. Much of the work of MEPI and NEPI utilized the ECHO platform, which stands for Extension for Community Health Outcomes, Healthcare Outcomes. This is a video conferencing platform that has been leveraged to share lessons learned through many of our programs, focusing not only on HIV, but when the COVID-19 epidemic hit, ECHO was a key resource that we used to share many of the lessons learned from our PEPFAR-supported projects, specifically looking at contact tracing, community healthcare workers. Many of those protocols that we developed for PEPFAR were easily translated to the local setting on the ground in the U.S. for COVID. This slide did not translate very well through the internet, did it? The HRSA Skill Sharing Program, which we refer to as SSP, is a continuous quality improvement program, and it creates a partnership between U.S.-based U.S.-based HRSA-funded healthcare providers and healthcare providers who work in our PEPFAR clinics. It's a hybrid distance learning approach that also has in-person contact, where we set up a peer mentorship program so that best practices and challenges can be shared in both directions. The program has been conducted in Uganda, and we're currently implementing in Jamaica and Ethiopia. I also want to highlight STRIPE, which is the Strengthening Interprofessional Education to Improve HIV Across Africa. And this is a multi-directional learning platform that is really focused on South-to-South best practices and learning. And finally, I want to highlight a white paper that was developed by HRSA, really trying to identify key lessons learned from the Ryan White program as well as key lessons learned from PEPFAR that can be shared. And this is really forming the basis for the next presenter, Alpha, who will talk about some of our current work and where we're going.
All right, maybe I'll go ahead and get started if the slides are, oh, there we go. Thank you, Jenny, so much for sharing the contributions over the past few decades and what we've really been doing in, during COVID and post-COVID, during COVID. I'm still not sure if we're fully post-COVID, but I'm Captain Alpha Patel Larson. I'm the Acting Deputy Director in the Office of Global Health at HRSA. And I'm excited to share some of the opportunities and platforms we're looking forward to exchanging best practices for sustainable person-centered health service delivery and systems throughout the world to end HIV as a public health threat. So with over 30 years of experience administering Ryan White and 20 years supporting PEPFAR implementation, we've been ramping up ways to really showcase multidimensional lessons learned between the high-income countries and middle-income countries, and also through South to South in that multidimensional way in the fight against HIV. So together, we've developed and delivered innovative, cost-effective, impactful programs focused on integrated health service delivery, health workforce development, quality management, and sustainable community-led health programs. And so I'll now remind you, as previous presenters did, that we had all co-authored together the British BMJ Global Health supplement, which Jenny and I have been summarizing, the Looking Back to See Forward, which also ties back to Tanshia's quote at the beginning, that we're looking back to see forward the multi-directional learning between the U.S. Ryan White program and the U.S. PEPFAR programs. And this article really does show both the case examples of GHRI between Ryan White and PEPFAR for optimizing programmatic impact. So we proposed going forward at least 10 areas to increase real-time sharing in a multidimensional way, listing here through 3 major categories. The first one on the left, sharing in collaborative forums. The second one in the middle around implementation science, and the third one around strategic health initiatives. So again, how do we fit in this session through the panel? Ms. Hayes mentioned most of how it really got, had been also part from the beginning, but relaunched in the last couple of years based on the lessons learned of COVID, and really making intentional efforts, not just happenstance, accidental conversations in the hallway with your colleagues to really expand those investments, but really that purposeful commitment to exchange those best practices in both U.S.-funded and domestic and global HIV programs is really part of a cultural shift across the federal agencies, as Ms. Hayes mentioned earlier. And as part of that sharing and collaborative forums that she described, this is the logo, really, that collaborative partnership really brings together all the staff working in policy, programming and research to really discuss those lessons learned and best practices. And we've had the 4 to 5 sessions of this forum since the initial one day that was brought up on a regular basis so that we can look forward to seeing how we can influence how we collaborate and even think about new projects where instead of having salvage evaluations and you think about evaluation from the beginning, where now how do we be intentional about GHRI and build into your projects or activities that continuous iterative process of multi-directional sharing. So with NIH, we also simultaneously, as we're working across the forum that I was mentioning before, we also got involved in GHRI that started a year and a half ago as well. And at the same time, HRSA had developed a global health forum process. And the good part is that we don't do these all separate. It's actually integrated. We're killing a couple of birds with a single stone, with shared and virtual webinar series on emerging health issues and promising practices to foster that sharing community. And we find the partnership invaluable. This alliance has really helped us be more intentional in how we define GHRI and sharing learning moving forward. Oops, I think I went backwards by accident. And then, Isa, our earlier chart, there's 3 other sharing and collaborative forums that we also rely on. We hosted maternal care in the U.S. and Zambia, and a COVID outcomes at the U.S.-Mexico border, and even did an agency-wide establishment of a bidirectional work group based on some of those work. We use this opportunity at conferences like this one, but also the International Maternal Health Conference session with NIH, and the HBCU, the Historically Black Colleges and Universities Global Health Consortium last year. And then next month, we have the Ryan White Conference, where we're also looking forward to highlighting GHRI in this with Ryan White providers, bringing them more as part of the SSP program that Jenny had described and expanding that expertise. We've also hosted a bunch of international learning tours with other country ministries of health and leaders, and that has been highlighting primary healthcare integration with France and continuous quality improvement with the Philippines. For the second category, we have 2 approaches to share. HRSA developed implementation science, IS framework to support the translation of data insights into real-world projects and maximize the program impact to achieve optimal health outcomes. And just a few years ago, the Best Practices Online Knowledge Sharing Portal was launched, and the IS approach also highlights the importance of the 3 items on the slide. I think I'm running out of time. And then as part of the SPINS program through Ryan White, we're utilizing implementation science to evaluate the design, implementation, utilization cost, health-related outcomes, while promoting dissemination and replication of successful interventions. And many of these SPINS projects have been based on lessons learned from PEPFAR. And then for the third category, the optimizing strategic health initiatives, we really do focus on with combined with all of our past and current partners, many of who's here today in the audience, ITech Jhpiego, UCSF, NetHIPS, and ICAP, Meharry Medical College, as part of the Global Health Consortium of Historically Black Colleges. Many of them have really helped do the 3 things that I've mentioned, and supported and leveraged and adapted to support in these ways. So we're looking again, advancing GHRI throughout all programs, projects, and activities to leverage the past and present investments, considering how quickly the future changes through strong technical assistance approaches. So I just wanted to take a little bit step back into the past again. There's a technical assistance framework that was used to strengthen Ryan White service organizations, and that was adapted to bolster capacity of host governments and local partners as part of Track 1 15 to 20 years ago as part of PEPFAR that based that platform. And then these human resources, treatment algorithms, best practices, and lessons learned really then did accelerate national treatment guidelines, clinical standards of care, rapidly built entire cadres of health workforce, and created additional frameworks. And this has really led to just a couple of years ago, distributing $8 million to Historically Black Colleges University for sustainable interventions to address the social determinants of health and health delivery systems, to close those stubborn equity gaps and persistent stigma across service delivery. I would love to talk more about some of those services that is provided, but we had a satellite session this morning. Please, I implore you to look and watch the video. It was a true triple dividend. and the intersection of health, education, and economic pathways that are life, generation, and game-changing. And that is because DREAMS graduates, adolescent girls, young women, were then trained to, were able to stay in school, were trained as community health workers. And then 4 initiatives that are up here in Zambia really address the structural barriers in health service delivery for the most vulnerable. And this really led to significant reduced interruption. And we're looking for more and more ways to share and package through the end of this year and next year how other countries through South to South and how we can bring those back to the US. So in conclusion, we're incorporating global health programs to accelerate these achievements and ensure country-led, sustained responses to public health and really achieve World Health Organization Sustainable Development Goals. And we're excited about linking those innovations to impact worldwide throughout, as all of the presenters and authors, co-authors have talked throughout the way. So put simply, we strongly believe if we do this work purposefully, that we can progress in meeting both our health outcomes targets and sustaining our efforts and the internal structure and capability to identify, produce, enhance multi-directional learning approaches that really will make that difference, as Chris's quote, or adjustment to the adverb really made very clear. So anyway, thank you for those that came to the booth this week. And welcome to that HRSA has to highlight this. Welcome to catch us tomorrow. Please register for the Ryan White Conference virtually. It is free. And check out these other resources to learn more and talk to us further. Thank you.
Hi everyone, I'm Al Liu from San Francisco Department of Public Health and UCSF. It's really a pleasure to be here tonight. Thank you for staying for this late session. And I'm not looking at the right, let's see. Keep going.
Yeah, there you go.
Okay.
They're pulling it up.
Oh, they are. Okay. Great. So while they're pulling up the slides, what I'm going to do is do a little bit more of a deep dive into a case study of global health reciprocal innovation, and specifically looking at in the field of digital health or mobile health. So the title is Exploring PrepMate by Welltel. So the innovation of using text messaging for supporting people with HIV was first evaluated in Kenya in a study called the Welltel study. So the Welltel intervention was a bidirectional texting service that also had a weekly check-in asking people how they're doing, and it helped triage people who needed additional support. So they tested this in a randomized clinical trial led by Rich Lester, and they found that it actually increased both antiretroviral adherence as well as viral suppression. So this was published in The Lancet, and it led to the inclusion of SMS texting and adherence as part of the WHO consolidated ARV guidelines. So we were really interested. When I first heard about this, I thought, wow, this is great. Could we actually use this texting technology back in the US, but to support people who were taking PrEP or for HIV prevention, so people without HIV. And at that time, there weren't really many interventions. It was just the early days of PrEP. So we thought this would be a great thing to test out. So we got funding from the National Institutes of Mental Health through an R01 to develop and test this mobile health strategy. We called it PrepMate. And PrepMate has all the core functionality of Welltel, but we also, through some input, also added some additional features, including web-based information. People wanted testimonials from other PrEP users, so we included that as well. So this shows the human-centered design process that we went through to tailor and adapt PrepMate for young sexual minority men in the U.S. And we had this session where we brought in all the youth, and people could draw pictures of what they wanted to include as part of the intervention. And one thing that was really important is that we wanted the intervention to support people at each stage of their PrEP journey. And so if you look at the bottom, it shows the different stages of PrEP awareness, decision to take PrEP, PrEP initiation, their early experiences, mid experiences, and late experiences. So we designed this adapted intervention, and then we tested it in an RCT called EPIC. And this was a RCT in about 120 young sexual minority men in Chicago. And people were randomized to either get PrepMate or Standard of Care, which was a brochure about PrEP. And in what you see is in the green are people who were randomized to PrepMate, and in the blue and the red was Standard of Care. And we looked at both visit retention as well as PrEP adherence. And you can see both visit retention and PrEP adherence was higher in the group that got PrepMate compared to Standard of Care, and this was across all visits. So we published the results in Clinical Infectious Diseases, and soon after, the CDC identified PrepMate as the first evidence-based intervention to support people taking PrEP and to support them with adherence and persistence. And since then, we've been working with WellTel to expand the availability of PrepMate through different ending the HIV epidemic jurisdictions throughout the U.S. One important thing we learned is that people had a lot of questions about the implementation and how it works, and so we were working with Jonathan Fuchs through a capacity building initiative to actually develop a PrepMate implementation toolkit, and so that's now available online, and I showed the link for that here. So this slide illustrates the reciprocal innovation of WellTel between lower middle income countries and high income countries. And so as I described, WellTel was first originally developed for ART support in people living with HIV. And then we adapted WellTel for the US for PrEP support. But pretty soon people were really interested in it for other fields and other purposes. So it was adapted for asthma, primary care, mental health, substance use, and even indigenous health in Canada. We also tailored PrepMate for Spanish-speaking individuals in the U.S., as well as transgender and non-binary populations, because that was a really important priority population we wanted to include. And then these innovations really translated back to lower middle income countries. They're using it for PrEP support, but they're also now using it for TB programs, COVID-19 contact tracing, PMTCT, and maternal health programs as well. So I was just going to end with some opportunities as well as barriers we encountered. The opportunities, as said in the first talk, this was an evidence-based intervention that really showed promise in terms of improving adherence, engagement, and satisfaction for people living with HIV. So we thought this is a great place to start. Why start from scratch? Rich Lester, who was part of the Kenya team, was really generous and offered to be a collaborator on our project, and he really helped us through the design process and gave us a lot of input, which was helpful. And as I mentioned, the WellTel model really has broad utility across borders and disciplines. In terms of barriers, initially WellTel was not available in the US. They hadn't developed their system, so we actually had to find a whole new tech developer and a vendor, and we went through several different vendors because we were having some challenges, and so that led to some delays. We've also encountered some local data security and compliance requirement issues, and that's different in the US versus lower middle income countries. And finally, we need to consider different sustainability strategies because the business and payment models are very different. And we have a lot of complex insurance and health financing landscape issues. And just want to acknowledge everyone who is part of the team to test and develop PrepMate, WellTel, and NIMH for supporting the research. Thank you.
So thank you so much to our panelists. So we're now going to have our next panel moderated by Dr. Glenn Shaw.
Good evening, everyone, and thank you so much for hanging in there through some technical challenges. We're going to re-energize and get back on track with our timing. So my name is Mary Glenshaw. I represent the National Institutes of Health Office of AIDS Research. For those of you who might not be aware, NIH provides the largest public investment in HIV research in the world, and our office helps coordinate those efforts. It's my great pleasure to introduce our speakers in this next session, which is about lessons learned from the Global Health Reciprocal Innovation Program. The first speaker is Dr. Chepchirchir Kiplagat. She's an assistant professor of public health at Moi University in Eldoret, Kenya. And Dr. Megan Song McHenry, who is an associate professor of pediatrics at Indiana University, is our second presenter, and she is online. As a quick update and refresher, Moi and Indiana universities began their academic partnership in 1989. They're true innovators in global health reciprocal innovation. This partnership continues to evolve, as you'll hear from our fabulous speakers who are sharing their perspectives from funding institution and grantee points of view. Thank you.
So thank you, Mary. Okay, I'll probably just go ahead as I wait for the slides to come up. So thanks again for introducing that. Talking about the program that today we're referencing, a coined definition of reciprocal innovation, is the Indiana Reciprocal Innovation Program. And I'd like to look at the lessons from GHRI program itself. But before I go ahead and talk about them, I want to give a brief background of a program that sure has led to who we are today at Indiana GHRI program. Learning from more than 30 years of partnership in Kenya, that began sometime back in 1989, where Indiana University and Moi University in Eldoret began an academic partnership. And in 2001, both institutions, along with Moi Teaching and Referral Hospital and a consortium of universities, joined together to establish what we now know as the academic model providing access to healthcare. Today, the AMPATH program is a model that brings together global network of universities and academic institutions collaborating with host academic institutions and their public health systems to support holistic, sustainable, and health system around the world. The program has grown, basically looking at its tripartite mission. It's been able to deliver health services and strengthen public sector health system, and in Kenya we've seen that expand to covering more than 24 million people across the country and specifically within the Western Kenya. It's a program that has strengthened the human capacity through training and education, and also advancing research and to address the health needs and priorities. A program that cumulatively has put together a grant portfolio of $250 million with publications of over 1,400 among the partner institutions. Today, in our midst here, sits two members of the program who actually were part of the initial development of the program, Professor Rachel Freeman and Professor Winston Nyandiko. So the program has grown, and with the success that we've seen so far, it's now realizing an even bolder vision as the model that is being replicated in Mexico now, Nepal, and Ghana. So we no longer have AMPATH Kenya only, we have AMPATH Global. What has kept us strong and keep to grow are the key principles that we hold dear, and that within this partnership, partners share belief that health is a fundamental right and generally holistic care is always needed. Besides, that programming within this partnership is designed based on the needs identified by the host partners, while also host partners lead the way in their own countries. We leverage the power and responsibility of institutions of higher learning and their health systems, while collectively making an impact, and making an impact not just within the local partner institution, but also in the international partner institution as well. One thing that we've always learned is the ability to make mistakes. But when we make mistakes, we self-correct. And as part of that, we've collectively built our reciprocal innovation by co-developing, co-creating with the key message of mutual benefit to both our partner institutions globally and also locally within Indiana University. So to go then specifically to the program that I was to provide the key lessons is a program that was established in 2018 as a module of Indiana CTSI program by the same team that has really stayed strong together in their collaboration within the AMPATH program. The goal of this program was to build capacity and basically institutional infrastructure for research that partners would really use and would facilitate and grow reciprocal innovation. The program has 3 components. I'll talk more about them, but these, the first component is the stakeholder engagement, where the program brought together stakeholders in Indiana CTSI program. The Indiana CTSI program constitutes Indiana University, Purdue University, and Notre Dame University, along with partner institutions in the AMPATH program and other LMIC institutions that they partner with, and members of local public health and community organizations within the rural Indiana. Through facilitated discussions and breakout groups that were initially held as in-person meetings and later moved into virtual meetings, these meetings served to educate people who are part of the team to really understand what's the concept of reciprocal innovation. But besides that, it served also as a disseminating opportunity on RI as well. Within these meetings as well, we identified shared priorities, the health priorities within Indiana as well as in the LMIC settings that were really the potential for reciprocal innovation. And then it served as a connection point for our local and global partners to begin developing relationships and also partnering in co-creation and co-developing activities. The second component of the program is the planning and demonstration grants. So what the program has done, it has developed 2 mechanisms of grants. The first grant is a planning grant, which is a 1-year grant of up to $10,000 that basically focuses on supporting investigators to build relationship and partnerships within shared priorities, but also so that they can be able to co-develop research projects together. Investigators who win this grant are also eligible to a 2-year grant, demonstration grant, that is that's up to $50,000 to support, some of the initial testing or adaptation of implementation of RI projects that they would have developed within their 1 year of planning. Since 2018, we've been able to fund 6 planning grants and 8 demonstration grants, totaling, since the program began, to about $530,000. Interviews that we conducted with awardees indicated that 92% of our grantees really felt that they had had deeper and new partnerships with their partners. But beside that also, that about 69% of them used the initial grant that they received to seek for more opportunities and received grants as well. The spread of our grants and how our reciprocal innovation grants have been awarded are seen in that map. And then the third component of the program is the learning and dissemination platform. We have never wanted to be mean with information, and that is not what we work within the reciprocal innovation. We want to create a platform where all of us learn. And this is an opportunity where we provide open and accessible information, where we share the learning, we share collaboration, and we disseminate information. So creating this global health innovation exchange platform has enabled our investigators understand who are engaged in global, or rather RI work, and what areas or what shared priority areas they are working on, what interventions are they using, and the next steps after the intervention that could be adapted or adopted or even scaled up. And what we call this platform is our RI in action. Megan will have in her presentation a link to this platform, and we encourage all of you to just go there, learn what is going on, what has gone on, and see what you can be able to adapt as well. We really look at wanting to grow, and as we look forward, we are also looking back as well and saying, what have we been able to learn? And for you to learn, you have to face challenges in some way. So there are challenges that we've faced as a program, and one of them is operationalizing the concept of RI. That led us to actually developing the platform where we share that definition. Connecting global to local partners can be challenging as well, and our hope is that as we spread this out, there will be connection among investigators who would bring together the ideas and co-develop, co-create as well. We run the risk of deprioritizing areas that are not often shared health challenges, when in essence they are priorities for a certain context. Because they are not shared, then they don't fall within that component of reciprocal innovation. And sustaining funding opportunities is usually a huge issue as well. But we've learned lessons through the process, the importance of planning grants. Planning grants have been very helpful in keeping, this relationship, facilitating the connections or connection points where we have our investigators share the learning and develop, adopt, and or adapt, or implement as well. RI is where we continue to learn from. And then prioritizing our core values, our key principles of equity, trust, and community engagement within our RFAs here. And finally, we are hoping to create an RI hub that will speed up multinational community academic partnerships and leverage the emerging partnerships that we continue to see. I want to acknowledge the very many people who've worked towards this RI program, the Indiana Reciprocal Innovation Program with the support of NIH, the authors and the program initiators here, and also the National Institute of Health, Fogarty, and GHRI for supporting and leading work in RI. Thank you.
Now that we've heard from Chiri about the infrastructure and administration of our Global Health RI grants, I wanted to share a little bit more about the process from a grant recipient perspective. So a bit about me. I am a pediatrician and an associate professor of pediatrics at Indiana University. And through the AMPATH partnership, I've been collaborating with Kenyan colleagues from Moi University since 2011. My research program is primarily focused on pediatric HIV exposure and neurodevelopment. But within this research program focused on HIV, we do find that some children are developing well, while others are falling behind. And so, of course, we set up pathways for them to be referred to pediatricians, which occurs, but we often find that there are very few resources for children with disabilities. And in listening to our Kenyan colleagues, we realized that there really is almost nothing for children with autism, and the only resources would maybe be in Nairobi, Kenya for them. And it's actually not so different from my own experiences in the United States. I grew up in a very rural area of one of those quote-unquote flyover states in the United States. And in some of those regions, people have to drive over an hour just to get an autism diagnosis. And to be able to receive daily therapy driving that far really isn't feasible. So we saw this shared challenge that we had and wanted to be able to do something about it. So Chiri has highlighted already within the RI program that there are these planning grants, which we fortunately received one of them. And this allowed us to further explore the topic in earnest with new investigators with autism expertise. We assembled an interdisciplinary team in both the United States and in Kenya to identify and understand more about the local needs, which we did through regular Zoom meetings and as well as a bidirectional exchange, which provided really fruitful insights from both sides of the pond so that we could learn what strengths and assets we could pull from each setting. So 3 of our Kenyan colleagues traveled to Indiana and 3 of our Indiana colleagues traveled to Kenya during this process. And with this time together, we were able to co-develop, adapt, and refine an intervention that we thought would really help caregivers in optimizing communication and behavior in their children with autism in both settings. So with this planning in place, we applied for an RI demonstration grant, which was really what made this intervention program possible. So we called it, it's a group-based therapy that we called PAPEA in Kenya, which means to float or rise up in Swahili. And it's called CAST in the United States. That stands for Caregiver Autism Skills Training. And while the format is delivered a bit differently in each setting, it's in person in Kenya and virtual in Indiana, the core teachings are really the same between the two. I won't get into it too much. Oh, sorry about that. But I wanted to just briefly show you the structure of the sessions and the topics that were covered within the 10-session program, 5 of which had a component of one-on-one training and counseling as well. And while we were just piloting the program just to see qualitatively if parents liked it and to see if some of the questionnaires that we had on caregiver distress, behavior, and communication really corresponded with what parents were telling us in interviews, the intervention was actually very well received. It seemed to improve various aspects of what we were measuring very well, especially in the Kenyan context where we saw large and significant changes in the scores that persisted even, 3 months and more after the program ended. So some of the key lessons that we learned during this process, I think, one of the biggest ones reflects a line in one of Maya Angelou's Human Family poems. We are more alike, my friend, than we are unalike. The shared challenges that we face, regardless of the setting that you're in, and working together to find shared solutions is something we've heard throughout this presentation and really helps us all advance further. And for us, the fact that getting to take care of their child with autism is such a huge challenge, whether it's the resources that are required to get to appointments or the travel or the lack of access altogether, we realized that developing programs for them and being able to do it in a way that's the most accessible possible was really very beneficial. Also, while we were developing the curriculum, we realized that sometimes we make things unnecessarily complicated in the US. And so, for example, in autism therapy, there's a concept like an ABCs, which is antecedent, so before a behavior, the actual behavior, and then the consequence afterwards. And our Kenyan colleagues were really concerned that this concept was really hard to translate and make digestible using that same ABC logic. And they asked if we could just call it before, during, and after. And to that, our US autism experts were like, actually, yeah, it is It does take a long time to explain the concept, and if we just called it before, during, and after, it does, get the point across, and it's so much easier for people to understand. And so that's what we changed, and we did it across the board for everyone. Alongside this, there's the concept that Chris Longnecker had mentioned at the very beginning. It's a very popular African proverb that if you want to go fast, go alone. If you want to go far, go together. So not only were we learning from one another as colleagues as we were designing the curriculum, but also our families were learning together. Having a child with autism can be very isolating, and with the added stigma related to disabilities in Kenya, it's magnified. Our US colleagues had planned on doing individual training sessions so that everyone could get more directed or focused care. But our Kenyan colleagues really provided insights about how much value is created when we come together and people have colleagues and peers that can really support one another, which at the end when we were doing interviews actually was almost as important, if not more important, than the actual intervention that we were delivering itself. And then finally, this intervention and project, I don't think would have been possible to be done in such a way outside of the established relationships that AMPATH has created in Kenya. There's such a deep trust and mutual respect that occurs between the partners that are working there. And it's really not only just part of the culture, but it's also formalized in the policy and procedures that we go through in doing work there as well. And it helps innovations like this to really flourish. And the fact that they gave us time to orient and learn from one another, and especially as we're bringing in new partners with autism expertise, really allowed us to invest the energy and time to make the project a success. And finally, of course, I'm the one that's presenting this work with Cherry today, but it's truly the work of so many others that made it possible. I'm so grateful for my Kenyan colleagues and team, as well as our Indiana autism experts and collaborators. And of course, in the audience there, a big thank you to Dr. Rachel Riemann and Professor Nandiko for your research mentorship and leadership in AMPATH over the years. If you want to know more about this project or any other RI projects done within the Indiana CTSI, this is the QR code that goes to the learning and dissemination platform that Cherry had mentioned before. And I also included Cherry and mine's emails if you have any additional questions. Asanteni sana, and thank you so much for listening.
Okay, thanks everyone for staying. I'm Diane Rausch I'm the Division Director at the National Institute of Mental Health Division of AIDS Research, and we're really happy to be partnering with our colleagues from NIH and our other HHS colleagues, as well as all the investigators that are doing this great work. So I'm going to introduce the final session, and it's entitled, How Can Researchers and Funders Operationalize a GHRI, or Global Bidirectional Research Initiative, approach in studies? So we have two virtual talks right now. I'm going to introduce both of them for the sake of time, and then they will go, and then Tanchia will be able to close us out. So the first one is going to be by James Deering, who's from Michigan State University and in the United States, and he is going to talk about effective translation of innovations across settings, lessons drawn from dissemination and implementation science. And the second one will be from Sage Ishimwe from the Institute of Global Health Equity Research at the University of Global Health Equity in Rwanda. And she will talk about effective translation of innovations across settings, lessons drawn, helpful implementation science models and frameworks and theories. So I'll turn it over. You'll see these two back-to-back sessions. So thank you.
I work at Michigan State University in East Lansing, Michigan, in the United States. I wanted to talk with you briefly here, especially about two lessons drawn from dissemination science and diffusion of innovation research. We have heard from a variety of presenters here about evidence-based practices and programs, technologies, such as the one that Al Liu just described, PrepMate, which was a modification of Rich Lester's work with WellTel. Those are the types of innovations that I'll refer to here briefly. They can be new practices, new programs, new technologies like PrepMate, or new policies. I wanted to communicate just two ideas with you in Munich, and first of all, That is that many of our best interventions are adapted, as probably all of you have experienced or at least know. What I mean is they're changed in the field once practitioners begin to implement them and try to sustain them in practice. And secondly, researchers or advocates themselves, people such as Al Liu or myself, oftentimes will reinvent our own innovations that we have tested and created, or that others have created and that we then want to apply to a new purpose. So reinvention and adaptation, reinvention by designers, adaptations by practitioners, both contribute greatly to global health reciprocal innovation translation, the movement of those interventions from country to country to country to country. And specifically, the two ideas I wanted to share are that the attributes of innovations themselves, focused on how costly they are perceived to be, how compatible they are perceived to be, how simple they are to understand and use, and then how effective they are as perceived by potential adopters. Those attributes or characteristics are a key for people, whether they are intermediaries or people at risk of something like HIV.
May I interrupt?
Those perceptions are key for them to, number one, become interested in an innovation, and then secondly, try the intervention. So if we disseminate effectively based on modifying or adapting interventions, they can follow a diffusion process, which is oftentimes characterized by an overtime cumulative curve like you see here. And the key to this curve is that not only are the attributes, those perceptions of the new technology or new practice itself important in driving an intervention up a diffusion curve, but also who adopts early and what is their degree of social influence relative to others. The social influence factor in diffusion is a key to producing this curvilinear shape when cumulatively graphing adoptions over time. Next slide, please. So two things, as I said. First of all, a focus on attributes, how potential adopters, whether people like nurses or policymakers, intermediaries, whether they perceive the innovation to have these advantages. And secondly, the importance of informal opinion leaders, or the partners we engage with, or those we want to affect. Next slide. This is just a list of those attributes I mentioned, and they include the key, the most important attributes in most studies of the diffusion of innovations. It is cost, compatibility, simplicity, and effectiveness, which account for most of the variance in adoption decisions of individuals among attributes of innovations. Next slide. When we talk about social influence, the picture looks a little more complicated here, this graphic, but in fact, it's very simple. All this sociometric map shows us is that influence is unequally distributed among a population of people or organizations we may wish to affect. So, for example, we may wish to affect all of the public health clinics in Kenya, or we may, on a smaller geographic label, hope to affect all of the community centers, or maybe even residents in a community in Kenya. So what we see in this diagram, these data are from the US in the state of Pennsylvania, is that the dots on this page, the numbers represent individuals, the lines represent their reported patterns of advice-seeking behavior in response to a simple survey we conducted formatively. So this becomes a type of formative evaluation data showing influence, who affects whom when making decisions about innovations, that then can be used by you when you are planning for the diffusion of an innovation. In this particular case, 12 individuals received over 70% of all nominations from 852 other individuals. So if you know who the 12 are, you have an excellent chance of affecting the decisions of the other hundreds of individuals, thus making this change process rather efficient. Next slide. Thank you for your attention, and I am happy to send an article here. You can see the reference at the bottom of this slide that explains the diffusion of innovation and its relationship to dissemination science in more detail. Thank you.
Good day, everyone, and thank you for having me. It's a great honor for me to speak to you this night. So I'll be speaking about effective translation of innovations across settings with a focus on helpful implementation science models, frameworks, and theories. With that, can move to the next slide. Oh, thank you. This is my outline for this talk. Next slide, please. So what is the scope of health innovation transfer from low and middle-income countries to high-income countries? For this talk, I'll be focusing on I'll be referring to the findings from a scoping review that my colleagues and I recently published in BMJ that was to review the health innovations transfer or exchange from low and middle-income countries to high-income countries. So the scope of innovation transfer, we all know that there are shared health challenges across the world, and this was highlighted during the COVID-19 pandemic. And if there are, we should also have shared health solutions or innovations. So the innovation transfer is a diverse array of initiatives that aim to address global health challenges, either through dissemination or adaptation of successful innovations. Next slide, please. Why effective translation strategies? We need effective translation strategies because, one, we need to ensure that a successful innovation in one context can be adopted in another setting. Second, we need to bridge the gap between research and practice. And third, to facilitate the translation process. Next slide, please. I would like to provide an overview of implementation science models, frameworks, and theories. We all know that implementation science aims to systematically close the gap between what we know and what we do. And implementation science models, frameworks, and theories offers a structured approach to understand and improve the adoption, adaptation, sustainability, and innovation across different contexts. Next slide, please. Here are some examples of the models, frameworks, and theories that are widely known. Among the models, the most commonly known is the REAMP, Reach, Effectiveness, Adoption, Implementation, and Maintenance model. For the frameworks, the mainly ones are, the commonly known is diffusion of innovations, theory, capability, opportunity, motivation, behavior, and the theories we mainly find theory of change, social-cognitive theory, and organizational change theory. Again, I'm focusing on the findings from our scoping review. There might be more than those, but those mainly what we found in the studies we included in our scoping review. Next slide, please. I would like to give some case studies of the models, frameworks, and theories we found that were used in innovation transfer from an LMIC to high-income countries or through exchange or transfer of innovation. One is there was the researchers from different countries with totally different income levels, such as Uganda, South Africa, and Sweden. They came together to co-create a community strategy to support type 2 diabetes self-management using frameworks for knowledge translation, evidence integration triangle framework, and theory of change. Across the process, they started by situational analysis in all contexts of the current situation of type 2 diabetes management, including self-management, if there were strategies in place, and also designing generic tools for strategies to achieve the goal of having that intervention across settings. and they contextualize the translated tools in different settings. I mean, all of the the 3 countries in their communities, which was successful using this framework. That's one of the framework and theory used. And next slide, please. There's also a health information model that was used in Kenya to map violence report, disaster impacts, and response in Kenya during the aftermath of the presidential election in 2007, and later on was used in the USA, in New Orleans, during the hurricanes to report chemical spillages and health hazard for quick response. This was translated through a model for reverse innovation in healthcare. Next slide, please. This brings us to the key consideration from our findings. The literature studying LMIC to HIC transfer of innovation is so small, and yet we need global learning in this setting. And the commonly used models, theories, and frameworks couldn't be identified from the reviewed literature because so many frameworks, theories, and models were used across several studies. We couldn't determine who are the common ones used. With that, there is that gap that we need to address, and we need to ask ourselves some questions that need specific answers. For example, are there specific models, theories, and frameworks to use when studying innovation exchange between LMICs to HICs? And if the existing one needs to be modified to accommodate some of the challenges and barriers to facilitate innovation transfer. Thank you for listening. That's the end of my talk.
So thank you, everyone. This concludes our session, but I want to just do something. I know we have run out of time, but if we can ask our presenters just to stand up and just acknowledge them all together in person, but also virtually, and then let you know who they are, because I know you're so excited about this. Over dinner, you're going to be talking about GHRI and bidirectional learning, and you're just going to be invigorated and want to engage with them later. So I just want you to see them again, and I would love to acknowledge them. And thank you to our virtual presenters online. We appreciate you and your patience and for your great learning. And so with that, if you can try and advance my slides, or no, that's okay, I can do this. Let's do this, all right? So I think what the message that we wanted to get was partnership and being intentional and purposeful about this, and making sure that it's mutually beneficial as well, and then looking at the equity in it, because I think oftentimes we think, especially in the U.S., that we know a lot, right? And we are actually learning a lot from other countries about their work. And so we have the opportunity with this to become an expert learner or listener, and versus, a TA person where we're saying we know what the problem is, we have the solution, but we actually can do this in a very sort of natural and organic exchange. And so that's what we really want to leave you with. We want to thank especially Ms. Kate Hayes for leading this effort from in the U.S. government and making sure our agencies are working together with that platform. I want to especially thank Diane for NIH for this partnership, and her team and other colleagues for that, and bringing us this illustrious panel, and also my colleagues at HRSA for providing the examples here today, and you for staying and sticking through our technology issues. So we appreciate you, and please feel free to contact us or any of the presenters here. Thank you so much.